Okay, okay.
Okay. If you are not sharing, then you can share,
Sure.
Dr. Ankur.
Yeah.
I have sent the flyer. Yeah, I just emailed the flyer.
There we go.
Yeah.
You can see, right?
Yes.
Yes.
Perfect. Okay. I'll wait a few minutes. Maybe two more minutes. Is that good?
Yes.
This is I can talk a little bit just about this picture while we're waiting. So this was in Florence last year at the ECP meeting, and we went to this uh, ice cream shop, gelato place that we liked so much that we went 2 times. And I'll never forget because we all ordered cups. We're all done here. We ordered cups, and Sambit ordered a cone, and he put 3 scoops in it, which is fine, but it was completely dripping because it was so hot and warm and humid there. So I mean, we're all just casually eating, and he's like scrambling, trying to like eat this thing. He's like dripping. His whole hand is covered, and the tissue papers are terrible. They're like cellophane. They're so bad. We were all laughing. It was just kind of a funny thing, just seeing him struggle to quickly eat this thing, in minutes. It was quite funny. So I'll never forget. Every time I have gelato. I was in Rome last week, and we had gelato with my family, and we all got cups, but I was reminded every time I have gelato, I think I'll always remember him. That was a funny
Yes.
story.
Yeah, this was a very memorable trip.
Yeah.
I also have a lot of photos of the Dr. Mohanty sent me,
Yeah.
during the trip while you all were at it.
Oh, I see.
Yeah.
Yeah. So just a moment. Let me mute all.
Sure.
Yes.
All right, then I am unmuted.
Yes.
All righty, I guess I will start. So welcome everyone to the third series now of this Dr. Sambat Mohanty lecture. And just keep online and keep posted. We'll have multiple flyers coming out for the next future talks, and Dr. Jazraman Dillon will be doing the next one. I forget. Dr. Lobo will post this after the session, but today I'm going to be doing my sort of second series in bladder, one of my passions in geopathology, and talking about bladder variants. And at the end of this, we'll have some time for questions. So I have quite a bit to go through, so I'll just kind of start and kind of dive right in. But everyone, you can still hear, correct? Everybody's good? Okay. So this table is from a recent ISEP consensus conference. It's lifted from the WHO, talking about bladder subtypes versus differentiation, and I will hopefully try to avoid using the word variants too much, because in the past that with these essentially were all kind of considered and lumped under the term variants, and I still slip and use that frequently in teaching and lectures and training and. But officially the WHO and other WHO, not even specifically GU, has peeled off the term variants for those that actually have a molecularly defined classification. And so rather than that, so they've split these off into subtypes of bladder cancer, and I'll kind of go through each one of these that are listed here, and then divergent differentiation. So the question you may say, well, what's the difference between these two? It's a little controversial, and there's some subjectivity, and if you slip, and even in your reporting, it's probably reasonable to kind of intermingle. But technically, divergent differentiation, you often can see those same elements in other tumor types. For example, a pancreatic adenocarcinoma with squamous differentiation. There usually really isn't a pancreatic carcinoma with lipid-like, and all these. So these are kind of more specific to urothelial. So that's one thing that these show overlap in other organ systems. And two, they often do show a unique immunoprofile and lose elements of typical urothelial carcinoma. So, for example, plasmacytoid urothelial cancer subtype still typically shows staining for typical urothelial markers. So that's kind of another breakdown between the terms subtype and differentiation. But admittedly, there's a lot of overlap. It's sort of, semantics in terms of nomenclature, but just sort of drawing your attention that in the older literature, you'll see the term variance used. And as I said, I still slip up and frequently will say that. In this consensus conference, it's from a couple of years ago now, they essentially asked the polling audience, should we be breaking these down, these subtypes and differentiation routinely? And overwhelmingly, consensus was 100%. Really, no cutoff. Any percentage should be included, even less than 5%. And importantly, you should be doing this not only on resection specimens, but actually on the smaller biopsies and transurethral resection specimens to sort of drive outcome and prognosis. And here's kind of it was a nice meta-analysis review. In general, compared to urothelial carcinoma, for the most part, they still had some similar predicted outcome. I'll kind of go through each one of these and why I think it's probably still important to break these down in your reporting. But there are some, excuse me, that are clearly important to break down, including sarcomatoid, micropapillary, and plasmacytoid. I would probably put in nested as well in here, but I think these three in particular have unique outcomes and likely inferior outcome compared to traditional urothelial carcinoma. So especially important to do and to isolate those. This is an old study coming out of Michigan, but it's one of my favorites, where they essentially looked at a consecutive series of bladder cancers that were referred to them for follow-up therapy and whatnot for patient care, and ended up kind of reclassifying a fair number of these into the various subtypes. So just kind of, the point of the paper was that in general, I think probably people are underappreciating and underclassifying some of these quote unquote variants or subtypes of differentiation. And I'll kind of go through some of these here in a bit. The one I probably will not talk about is neuroendocrine, because it's actually not in the WHO, and it's a whole separate really lecture or topic. But okay, so let's talk about micropapillary carcinoma. Again, these are all subtypes. This is an aggressive urothelial subtype first described by Dr. Amin in the Bladder in 1994. It's typically a component of regular urothelial carcinoma. Oops, hold on one second. Let me make my thing full screen. I lost it. There we go. Oops, I did it again. Okay. And it resembles micropapillary carcinoma or other organ systems. So that if you sign out other or tissue types of organs, you probably have seen that terminology in the lung and breast and other things. It's typically in bladder as high stage, either on biopsy or subsequent cystectomy, and even when present focally, there's a high incidence of lymph node metastasis, and frequently in the metastatic sites, it will often show the same MPC-like pattern maintained in the metastasis. There's some controversial neoadjuvant chemotherapy, depends on the institution where you're at, but in general, at least for HER2, there's typically a higher rate of HER2, at least by FISH, compared to traditional urothelial carcinoma. So there is some targeted, eligibility or importance of recognizing this in the neoadjuvant setting. I want to draw your attention to this sort of gold standard study out of the MD Anderson group over 10, almost 20 years ago now, really kind of drawing the attention. So typically for managerial implications for bladder cancer in the past, unless you were florid CIS or at T2, so muscle invasive, that was essentially the indication for a urologist to then proceed with cystectomy. But because micropapillaries have such an aggressive behavior, this study essentially stratified patients, a group of patients with micropapillary that were non-muscle invasive, so T1 at the time of biopsy, into either BCG, cystectomy, and then followed or immediate cystectomy. And you can see here the ones that did BCG really did not respond, although the ones that had immediate cystectomy essentially did have a significantly higher survival rate. So the conclusion for this is, really therapy and other things are really not effective. And essentially, it was the first time that it gave the urology groups the green light to proceed with cystectomy for PT1, so non-muscle invasive micropapillary disease, which was kind of unheard of at that time. I think we all knew that, suspected that micropapillaries did do worse, but this was the first study, kind of gold standard, kind of showing that. The problem with that is, well, if you've signed out urothelial cancers, you know that it typically invades in a retraction-like fashion here on the right. Sometimes with small nests, But in contrast, micropapillary carcinoma has a potentially challenging overlap with traditional urothelial carcinomas. On the right, I would not consider this as urothelial MPC. On the left, and I'll kind of explain here what the criteria that I use and others use for the diagnosis. But there can be overlap morphologically, and as is shown clinically, it's quite important to make this recognition of micropapillary, even if there's a small amount. So how do we define micropapillary? There's a lot of literature on this that's out there. In this meta-analysis that we did for a paper several years ago, and you can see the very first definition was, out of Dr. Amin's group, and essentially saying it's sort of akin to papillary serous carcinoma of the ovary. And then subsequent papers that had various numbers of series sometimes essentially referred to the original 1994 description or had their own, description, tight tumor balls, small lacunar nests, avascular clusters, or they just refer to the initial depiction. So there's kind of, people are using these terms, these definitions kind of interchangeably and somewhat somewhat differently, which is kind of a problem if you're essentially publishing and posting, outcome-based studies. So what we did in a study, I said almost 15 years ago, essentially look at a large group of expert GU pathologists, hand them a series of cases cases that we classified as either MPC or non-MPC or borderline for MPC, and we had a list of morphologic criteria and see how the pathologists clustered along with the various morphologic criteria. And in this review, we found that these were some of the features that were either sensitive and specific with an overall accuracy. And you can see some of these ones were essentially having multiple small nests, which you sort of think, oh, okay, that's kind of if you see a whole bunch of tiny little nests, that's probably micropapillary carcinoma. And again, it's highly sensitive for it, but the specificity is quite poor because urothelial cancer frequently invades with small nests or extensive retraction. You can see here, but the top players that we found that were most helpful are finding multiple nests in the same lacunar space, having intracytoplasmic vacuolization, and I'll show you some images here in a second of this. Epithelial ring forms, you get some lumen formation within the tumor nests, peripheral nuclei, back-to-back lacunae, or having little micropapillae, meaning tumors without fibrovascular pores that were kind of elongate. So here's kind of a nice prototypical example on a cystectomy specimen of pure micropapillary carcinoma, multiple nests in the same lacunar space. You can see this thing is deeply invasive into the muscular fat, transmural fat here, but multiple nests in the same lacunar space. Yes, the tumor nests are small. They usually are. They're not large, but there usually are multiple nests in the same lacunar space, and immediately you can see some areas that have some vacuolization. But I would say that multiple nests in the same lacunar space is probably, I'll say it over and over again, that's my favorite feature, and I think that's the most useful feature. But these epithelial ring forms I actually find quite helpful if you kind of crawl around and look. And again, here this is what I'm talking about these. So this one only has one tumor nest in the space. This one has multiple, but these epithelial ring forms in the lumen, as well as this sort of vacuolization. Sometimes the nuclei are peripherally located. The cytoplasmic vacuolization is kind of a helpful feature as well. But the problem is, you're looking at this case and your sort of eyes are drawn to these large, slender papillae of this non-invasive component. And then just here in the corner is the invasion, and it's not only invasion, this invasion is all micropapillary. And that's the more typical pattern as you see is it's not a pure sense. It's kind of subtle in various percentages. And I think identifying that can be quite helpful. But if you're looking for it and keeping an eye, and this one has more of this elongate-like pattern, typical for micropapillary urothelial carcinoma subtype. So here were images from our paper that we looked at. So these were all ones that we considered micropapillary. And for the most part, most people tended to agree, but, some people tended to essentially overcall some of these as micropapillary. Most people tended to not undercall. It was more of an overcall. And these were ones where essentially sheets of tumor cells, multiple nests in the same lacunar space. But some of these are large, some of these were small. I'm sorry, not having multiple nests in the same lacunar space, but having extensive retraction artifact. These were features that we did not classify as MPC. But admittedly, there are some cases that are sort of borderline. It's like, what do you do? And, these can be somewhat challenging. And sort of recommendation I have is to essentially show it around, get us some expert consultation if you haven't seen these or are feeling uncomfortable with it. And sometimes you can't tell, you can sort of hedge, but it's a big deal for the urologist if you're going to pull the trigger for a micropapillary. In case it's muscle invasive, it probably may or may not matter. But if it's not muscle invasive at that point, it does make a big difference. So immuno, can you use immuno to sort of sort this out? In breast pathology, there is some literature looking at MUC1, which is the same thing as EMA. as well as some other markers, at least in bladder. So this was a paper that we did, a kind of a follow-up study to that, just saying, hey, can you use this immunohistochemistry? Because as pathologists, we're all looking for that immediate fix to sort of helping us arrive at a diagnosis, especially if some a new stain or a potential pattern of a stain comes along. And this is the sort of reverse apical pattern that is sort of in textbooks and things that people talk about, where the nuclei are, because these things essentially peel away from the basement membrane. They essentially peel away, and so this is MUC1 or EMA had this reverse apical staining pattern. But if you look at enough urothelial carcinomas, this is invasive urothelial carcinoma with extensive retraction, it can frequently also show that reverse apical staining. So in contrast to the complete membranous staining, as I said, this reverse apical, so it's not specific. And then CA125 similarly, and HER2 can also is not entirely sensitive. So I really want to draw your attention to not, at least in bladder, to not use EMA as a differentiation to kind of help you. It's quite sensitive, but specificity is poor enough that you really should not be using it. It really should still be H&E morphology to kind of sort that out. So that's micropapillary carcinoma. In brief, I just want to talk about, although I'm mostly focusing on invasive tumor, talk about non-invasive micropapillary, because I think that's a really important point. The fourth edition of the WHO, I really like that they kind of highlighted specifically that if you sometimes see a non-invasive component, so essentially, and I'll show you examples here in a minute of what I mean by that. But if it's non-invasive, that tumor really should not, don't use the term micropapillary at all in your diagnoses for a non-invasive disease. The fifth edition didn't exactly kind of tease that out. They kind of expanded and explained that non-invasive papillary urothelial carcinoma can be micropapillary, can be viloglandular, this and this, but they actually didn't spell that out. You probably should not be doing that. I wish they had done that, and I'll explain what I mean here, why. So if you've signed, this looks almost like a ovarian serous borderline tumor or a micropapillary tumor of the ovarian. This is actually urothelial carcinoma that has a sort of filigree-like, I should say not micropapillary, a non-invasive papillourothelial carcinoma with non-invasive papillourothelial carcinoma with micropapillary features, with these sort of elongate filigree-like pattern of tumor cells. So it looks, I mean, morphologically, it is micropapillary in a sense, but in your pathology reports, you absolutely should not be doing that, because when you say the word micropapillary, you're implying invasion. Even if you say non-invasive, a lot of urologists will not understand what you're talking about. So, but this is just for depiction purposes, because it looks weird when you see something like this. It looks unusual. This is what I mean by so-called non-invasive micropapillary carcinoma, where there's no fibrovascular cores in this thing, but you have these elongate, slender papillae. And typically, you do have some traditional papillary, non-invasive papillourothelial carcinoma as well. And I tend to keep this in the camp of a kind of a viloglandular or a glandular pattern. That's kind of why I sort of lump it under as the WHO does, the fifth edition. So on the right here, you have this non-invasive micropapillary component. On the left, you have the more typical kind of viloglandular. It's all non-invasive, but the more kind of cribiforming looking thing. And sometimes the two components can kind of intermixed. And then other areas can be more viloglandular. Again, I tend to lump all these as non-invasive glandular elements, whether it's viloglandular, cribiform, or micropapillary. So the real question is, why, you're saying that this non-invasive micropapillary doesn't matter. You really shouldn't be using that terminology. Is there any data? And there is. We did the study showing that really stage to stage, they show a similar stage progression to typical urothelial carcinoma, and then importantly, in our series, there really was no association to the invasive micropapillary component. So for that reason, I just do not mention anything in the report. If it's non-invasive, you can take pictures of it and share it and post it, and show your trainees and whatnot, and stare at it and admire it, but absolutely do not use that term non-invasive micropapillary in your reports. So how about the non-invasive glandular? Does that matter? Should you be commenting on that? I actually do. And I think there's these two series that show that if there's non-invasive glandular differentiation, that there oddly is a higher association of small cell cancer in follow-up. So I actually do mention that. So here's a case that it wasn't on the follow-up actually here. So you have some traditional papillourothelial carcinoma here, and then other areas you have this sort of viloglandular-like appearance, which is in keeping with a non-invasive glandular pattern, papillary urothelial carcinoma, and right smack in the middle, you actually have small cell cancer. coexisting as well. So again, in my experience in the literatures, these patients, the non-invasive glandulars often have a higher association of small cell. So when you say non-invasive glandular, what do you mean? What do I mean by that? You have to make sure you're not looking at these little microcysts. Urothelial cancers frequently will have these little microcysts as well. So this is not what I'm talking about with glandular. It's really true elongate enteric looking thing, either an aviloglandular, cribriform, or a non-invasive micropapillary, so to speak. But just having little cystic spaces does not make it glandular. Neither does actually having mucin. This is just a typical papillourothelial carcinoma, non-invasive, that happens to have a little cytoplasmic mucin. At least for me, I do not. It has to architecturally look glandular to call it. Just having mucin alone doesn't do it. This is not that common, but it can happen as well. So, okay. Next, I'm going to move on to plasmacytoid urothelial carcinoma and essentially start with the case. Here's a TURBT of an erythematous lesion that was biopsy. I think overlying, you do have some high grade looking non-invasive component here, more typical looking urothelial carcinoma. And then down below, you have this solid area, but kind of sheet-like tumor cells kind of floating out into space. Seemingly invasive, but oddly kind of monomorphic and bland. In some areas have these kind of cytoplasmic little luminae kind of floating out into space, and has given, if you haven't seen this, can give you quite of a wide differential in addition to plasmacytoid, which is obviously the diagnosis in here, but melanoma, lymphoma, other things can give you that kind of morphology. But this is kind of a nice prototypical example of plasmacytoid urothelial carcinoma, and it typically occurs like in other tumor subtypes as a component of other elements. Not rarely is it often just pure. The CAP actually lumps plasmacytoid with signet ring cell and diffuse, so kind of a overarching thing. But the one question I sometimes get is, sometimes you do get little signet rings in a mucinous adenocarcinoma. So in that case, if there's extracellular mucin, that's not really plasmacytoid. You may have some luminal cytoplasmic mucin, but it's not extracellular mucin at all. It typically comes, and I don't break these down in the report. It's more of a kind of a morphologic appreciation. It's the classic form. I kind of make this akin to lobular breast cancer. There's like these very bland, lymphocyte-looking tumor cells. That's sort of the classic pattern. The pleomorphic pattern, I'll show you in a minute here in a second, but it typically has more pleomorphic nuclei, a little bit more angry-looking nuclei. And again, I kind of make that akin to pleomorphic lobular breast cancer because they have very sharing overlapping morphology. And then there's a desmoplastic pattern, which is pretty hard to appreciate sometimes, but it's infiltrative plasmacytoid tumor cells with an associated desmoplastic stroma, which is a little unusual. So plasmacytoid, I think one very important point to remember is that in addition to having a poor prognosis, they frequently will be associated with intraperitoneal spread, akin to actually, again, lobular breast cancer is well known to do that if you sign up breast as well, and frequently having positive margins. So intraperitoneal spread and positive margins for ureter margins especially is really unusual compared to other urothelial carcinoma subtypes. So here's kind of a nice prototypical example at low power where you do have some tumor cells here, the more typical, especially quite solid, but this is actually plasmacytoid urothelial carcinoma, but really can be quite subtle that if you're looking at this at low power, even on gross exam, looks like essentially it's not your typical sheet-like infiltrative tumor that I showed on the 2 lectures ago when I was talking about bladder cancer staging, but frequently these things essentially melt through the wall, often deeply invasive and often with associated lymphovascular invasion as well. So it can be quite subtle on gross exam as well. But the problem with this is actually frozens with this one. So here's a case, and when you're doing these ureter margin frozens, your eyes are obviously drawn to the luminal surface because the ureter, that's the margin that they're looking at. But when I get these margins, the first thing I actually always look up or ask the trainees if they're bringing to me or the fellows is, what was the prior? Oh, it was bladder cancer. No. It's obviously, it was presumably invasive bladder cancer. What subtype? Was it traditional? And then the reason why is for cases like this. So your eyes are sort of drawn here. You're looking at the lumen. It's a little bit reactive. You say, you know what? That's totally fine. That's in keeping. You may or may not have had chemo. That's totally fine for reactive changes. So looks like a negative for your margins are negative for carcinoma. And I think these images, I think would be, to me, that's still in keeping with kind of a reactive pattern. Totally fine. However, when you check the periphery in here, you do have some lymphocytic inflammation. We typically do see in these ureter margins, you do actually have some melting tumor cells kind of very subtly throughout in here. And that's the things with ureter margins on these plasmacytoid variant carcinomas. And you look at it and you stare at it like, oh yeah, that's clearly tumor, but your eyes are not drawn there. So at least on for if I know specific, I mean, not for all ureter margins, I would encourage you to do this, but especially if it's plasmacytoid, I do a double pass and check the periphery because frequently you'll have areas of potential. I shouldn't say frequently, but it can be it would be a very bad miss to have that as and calling that a negative for cancer. So check the periphery on your frozens for your ureter margins for especially plasmacytoid. So 138, please do not use 138. I get this frequently on consultations and incoming cases from the outside and external reviews where they've done 138 and said, well, that supports typical plasmacytoid. For the most part, it's still morphology. There's some immunity that you can use, but 138 is not one of them. It typically will stain other urothelial cancers as well as, lymphoma, myeloma, as you may know, anything rhabdoid or eccentric looking nuclei is going to stain plasmacytoid. So do not use, it's going to stain 138 with 138. So please do not use 138 at all. If you're at all thinking, if you want to chase it for lymphoma and other things, that's all fine potentially, but please don't use that at all. So the reason why that it has this sort of unique morphology, again, akin to, I'll say this again and again, it's very akin to lobular breast cancer, is that plasmacytoids have a loss of E-cadherin, typically due to CDH1 mutations or promoter hypomethylations, one of the two. And in general, it's almost 85%. And it's quite specific. So if you're doing molecular, you don't necessarily need molecular, but compared to all the other urothelial carcinoma subtypes, they don't have that. This is a very specific feature for plasmacytoid. However, in contrast to gastric cancer and other things that are, CDH1 mutated, there's really no associated germline mutation. So these are traumatic, interestingly enough. But that CDH1 mutation is interesting because you actually can use E-cadherin to show that these essentially do stain like lobular breast cancer. And I'll show you an example here in a second. But let me explain what I mean by P120, because most folks have probably talked about E-cadherin or are aware of it, but may not know about P120. So E-cadherin and P120 are essentially membrane complexes that sort of work hand in hand. And typically what happens in lobular breast cancer and lobular neoplasia is that when you lose the E-cadherin staining, P120 gets aberrantly translocated into the cytoplasm and gets upregulated. So in a lobular neoplasia fashion, like for example, this is a nice dual color example here. So you have a benign duct and this invasive lobular carcinoma. You have some retained membranous staining for E-cadherin, and all the invasive lobular breast cancer is lost for the membranous E-cadherin, and there actually is over a membranous red that's just being masked by the brown here. But with the lobular neoplasia, it gets aberrantly translocated into the cytoplasm and gets upregulated. So if you're able to do it in a two color, that's fine. You don't have to, but it's really pretty. On lobular cancer, it's one of my favorite combination stains to use because you get this beautiful red cytoplasmic with loss of membranous E-cadherin. But we did a follow-up study saying, hey, that works in breast. How does it work in bladder? And it works almost identically. So it can actually be a really helpful tool. You don't need it if it's classic H&E, it's not required, but there's some cases. So this is an example of this sort of pleomorphic pattern I was talking about. So that sort of melting pattern, I think you're more typical, lobular or plasmacytoid pattern cancer. But when it looks like this, it can be a little trickier for the plasmacytoids. And this is the desmoplastic pattern. These almost look like essentially crushed tumor cells, but if you look, there are some of these that have this sort of eccentric looking nuclei. So, and again, in general, it's pretty specific. There are some urothelial carcinoma subtypes you have to be a little bit careful with, especially, sarcomatoid, for example, can also show this pattern. So, but again, sarcomatoid's not going to look like plasmacytoid, so it's not an issue. But compared to typical urothelial carcinoma, if you're not quite sure, this combination can be really helpful. If you don't have P120, that's fine. Really, E-cadherin and or P120, we have both in my lab, so I tend to use both. But it's just a nice stain to kind of recognize. So it's way better than 138. So either use H&E or use E-cadherin loss to support plasmacytoid urothelial cancer. And as I said, it's about 80 some odd % sensitivity. So if it looks like classic plasmacytoid and it shows retained, membranous E-cadherin, you can still call it. Just something to kind of be aware of, or potentially even do molecular. So, but the importance of that is a case like this. So this was a case with multiple tumor fragments or other areas of solid pattern here that are invasion. But when you're staring at this at low power, it just essentially looks like a solid ball of, maybe invasive, wall to wall. That's a different issue. But you see these delicate branching intervening septae. It looks essentially at this power like a solid pattern papilloepithelial carcinoma. However, when you go to look at that, you can actually see that many of these nuclei are pulled off to the side and have this sort of eccentric localization with some cytoplasmic eosinophilia. And then focally, when you check the periphery, here's some normal overlying urothelium where it kind of falls apart. Then you potentially appreciate that, oh, this is actually all plasmacytoid urothelial carcinoma. And here's the ECAT hearing showing retained membranous reactivity as well as P120 and loss in the cytoplasm, loss in the tumor with overexpression in the cytoplasm for P120. So that's where you get in trouble. So if it's classic H&E, you don't need it. It's cases like these where you're like, oh, this looks a little weird. That's where I do the stains. And it's a big deal to pick this up even on a subset. So that's plasmacytoid urothelial carcinoma. So next, I'm going to talk about nested pattern urothelial carcinoma. And I'll start with a case. So you have this kind of overlying urothelium in here, and then you have these, small, bland-looking, nests. There are quite a few of these. So you do have some smaller-looking ones here, and I'd say that these probably look fairly similar. So on a superficial biopsy like this, you might think, oh, is this potentially just florid von Bunn's nest proliferation? And I think that's something that's totally in the differential. However, fortunately, this is a cystectomy specimen, and these tumor nests are essentially melting through the wall through the muscularis propria, and this is obviously, not surprisingly, an all invasion, and specifically a nested pattern urothelial carcinoma. So that's the pitfall I feel more than anything is sometimes you just get these superficial biopsies, and I'll show you some examples, some real life examples where you could potentially get in trouble. And here's another example here. You get these small superficial nests, but you can see these things when you go in higher power examination, they essentially kind of keep going through the muscular wall, and you do have some mitotic activity in here, which would be highly unusual really in a typical pattern or von Brunn's nest proliferation. So this is an example of what I would consider a small nested. So the nested comes in two flavors. They come in a small or large. Prognostically, there's really no difference between the two, but large is pretty uncommon. It's really the small that gets you in trouble with the florid von Brunn's proliferation. But you don't want to overcall nested either. The other question that I sometimes get is and here's the higher power image showing that mitotic activity in there. So this is a small nested pattern urothelial carcinoma. No stains, no levels, nothing else really needed. There's more mites here as well, just an H&E thing, but it can be quite bland. Here's another example where at low power, you probably do have some von Brunn's nest proliferation, and it's quite busy in here, but really there's no stromal desmoplasia. And so that's the thing. You don't want to necessarily overcall nested. If you have an obvious invasive urothelial carcinoma that's not necessarily forming papillary cores, it's just a high-grade looking tumor, angry, high-grade looking nuclei with desmoplasia. If it happens to form little small balls, in a seemingly nested, I don't consider that nested. Nested to me looks bland, and essentially if in isolation essentially looks like von Brunn's nest proliferations. They can have mites and things, but they should be quite bland with no desmoplasia. That's where I use the term nested. So you don't want to, if you have a raging, invasive cancer that happens to have a small ball pattern, so to speak, you don't want to overcall that as nested. But overlying, you can see this, that can be quite bland, but here this thing is obviously splaying the muscularis muscularis mucosa fibers in here, and MM fibers, so invasive into the lamina propria, which no von Brunn's nest proliferation should ever do, and maybe some potential mitotic activity. So again, this is another small nested pattern. This is far less common, a large nested pattern, but essentially, not so much von Brunn's nest proliferation, it sometimes just looks like tangentially cut. You look at this, you're like, oh, it's just a funny cut of the overlying papilloepithelial carcinoma potentially, or just a thickened area, but you really shouldn't have a nest wall, like a large nest like this, sitting in surrounded by circumferentially, and it's splaying thick muscle bundles in here. So this is a large nested pattern urothelial carcinoma, still within the family of nested. So important pathologically, mainly because these are bland, deceptively bland, resembling normal von Brunn's proliferation, but often deeply invasive. It's questionable whether these are actually more aggressive. I think the biggest issue is, unlike plasmacytoid and NPC, they're just often diagnosed late. So I think that's the issue. They essentially present at higher stage. That's my sort of opinion on these. Is it's not necessarily a worse prognosis. It's just people miss it, or they just don't sample the top of it, and it's because of a sampling issue. Just one important pitfall: they can be Paxate positive, so that's a potential pitfall, unlike other urothelial cancers. And in some cases, you can use TERT promoter mutation. It's not specific for this particular subtype, but if your differential is, von Brunn's nest proliferations, that can be quite helpful. So here was a case that I had pretty recently. You had some, very, very flattened looking urothelial proliferations, and then off the edge in here, you had some areas that were a little bit more kind of back to back and nested and a little irregular, and it wasn't exactly deep, so it's not splaying muscle fibers. So it just bothered me enough. It was very monomorphic, and so I ended up sending this for TERT, and it came back with a TERT promoter mutation. Did I call it nested? No, I just essentially called it a typical nested proliferation. It still wasn't quite enough to me, but it just bothered me enough that there's no way I could just blow this off as something reactive. And follow up that was done, you can see in here now you have full-fledged, more obvious nested pattern, but so you can see, and this thing is actually splaying a muscular mucosa fiber in here. So it's more typical nested pattern urothelial carcinoma. So it was a nice real life case of utility of TERT promoter mutation. If you can have it, that can be quite helpful. So a nested pattern there. Another important differential for nested pattern is pseudocarcinomatous hyperplasia. And what the heck do I mean by that? Typically this, and I'll show you pictures, typically this is often associated with prior chemotherapy or radiation, but not always the case. Sometimes if, injury, self-catheterization, vascular disease, and the sort of trifecta that you see with this, and I'll show you images, is you get these rounded, reactive-looking urothelial nests. They're frequently squamoid and they're wrapping around vessels. Then you get stromal hemorrhage and fibrin thrombi and edema. And so you essentially look at this at low power and it's like, whoa, this is a very bloody looking thing. Your gut reaction is reactive, but then when you see these rounded, irregular nests, they look a little unusual. And you get these radiation type fibroblasts and vascular changes. So here's kind of a nice example of what I mean. And if you've seen radiated, urothelial cancer or I'm sorry, radiated bladder, and it's usually patients that have prostate cancer or something else like that. But the urologist may even think this is a tumor. It looks very angry to them. But this is one that I've seen lawsuits for, and I think probably one of the benign mimickers that's probably more missed often is and called invasive cancer than any other benign mimicker is this radiation cystitis. I don't like the term pseudocarcinomatous hyperplasia all the time. That's the official one, but I sometimes just do it descriptively as, reactive something, or if the patient's been radiated, I'll just say consistent with radiation cystitis. But this is what you get. There can be seemingly deep, even sometimes with some mitotic activity, but you get these rounded nests with the sort of squamoid type cytoplasm, which you get this intimal hyalinization in the background vessels, so that can be really helpful. But they often wrap and round the vessels as they go down. They essentially kind of packet themselves all the way down, just hugging the vessels as they go along. So that would be a little unusual in a benign thing. So this is a nice example of so-called radiation cystitis. So something to kind of be aware of. But the chromatin is kind of smudgy, more eosinophilic looking cytoplasm. But if you're before you're entertaining a nest, at least check the background periphery and the vessels and see, at least consider, because they may not give you a history, and if you have to dive into it, the patient's been radiated or gotten prior chemo. Okay, so let's move on to tubular or microcystic urothelial subtype. I'm lumping this with it's tubular. They frequently go well. They're two different morphologies. Number one, so here on this lower left in here, you can see this thing is obviously invading into the muscle wall here. And I'll show you higher images. But you see these little microcysts in here. That's more. This is what I mean by sort of tubular or microcystic pattern urothelial carcinoma. But up top, this is actually a nested pattern urothelial carcinoma. So I'm showing you this at least partly to explain two things. One, frequently these subtypes occur in multiple patterns. It's rarely, for teaching purposes, just one and then one. It's like you get your urothelial cancer and then you get micropapillary. You get your this and you get nested. Sometimes you get a bunch of different things. You get a nested, you get this, and they essentially just break them all into the report with percentages. Sometimes you can't tell, you just do the best you can. But in my opinion, in my experience, this sort of tubular or microcystic frequently co-occurs with nested. They're seemingly cousins for some reason, and almost like the nested, as it invades the tumor nest, they're quite bland. They essentially open up the lumens, and as they do, they look kind of microcystic. So on the right in here was the same case. That was more of a nested pattern, and on the left is the so-called tubular microcystic pattern, but super bland. But you may, well, how is this not just florid cystic glandularis type thing, which is one of the top differentials? That shouldn't be splaying muscle fibers like this in here. It has subtle atypia, and obviously this has mitotic activity as well in here. So those are kind of two things against it. But it's a sort of gland-like lumens. It's really not a true form of adenocarcinoma. There's just these little microcystic spaces. It can be typed deceptively band, as I said, nephrogenic adenoma or cystic glandularis, and these are frequently deeply invasive with a high recurrence rate. It's pretty uncommon pattern, but I said I see it more often when I see nested. You see the nest where the nesteds open up. I consider that kind of a tubular or microcystic pattern. So the next one I'm going to talk about is lipoid. urothelial carcinoma. Here's a nice kind of a low power example of you get these overlying papillary urothelial carcinoma fragments and admixed amongst these invasive tumor nests in here. You have this kind of lipid or sort of vacuolated looking tumor cells in here. There are probably some traditional urothelial pattern carcinoma here, but for the most part, in this example, is a pretty florid lipoid or lipid rich urothelial cancer with these little vacuoles. And if you sign out soft tissue or you have an interest in it, you may immediately jump and say, well, boy, these sure look like lipoblasts. And I will tell you, that I would agree with you that they definitely do. And that's definitely a big mimic in here. So it has a sort of lipoblaст-like. They're not true lipoblast. These are not fat. These are actually urothelial carcinoma. They're epithelial, but they sure as heck do look like liposarcoma. So that's something to definitely at least kind of consider. So lipoid or lipid rich is they're both synonymous. They mimic lipoblast, but are not sarcomatoid. This is not sarcomatoid urothelial carcinoma. I don't think I've ever seen a sarcomatoid. You can get heterologous elements where I've seen liposarcoma as the subtype. That would be pretty. It theoretically could happen. I've not seen that. It can mimic glycogen-rich, and I'll show you an example here, a subtype, but typically you get some overlying regular pattern urothelial carcinoma. And in general, for most of the subtypes, most of them, they do poorly compared to the traditional urothelial carcinoma. So that's, I think, kind of one overarching thing. There's some data of like, obviously plasmacytoids and micropapillaries do worse, but in general, that's the reason why. I think in that survey study, they essentially said, hey, if you have any subtypes, just mention it and give the percentages because I think it does matter. So the top differential, as I said, is liposarcoma, but both liposarcomas would be negative for keratin or epithelial markers. So that, recognizing is, if you have some background traditional urothelial carcinoma elements, you're essentially home free at that point. But this is a huge pitfall is if you're all thinking, oh, is this potentially some, let me do MDM2, either immunoamplification. These lipoid or lipid rich can definitely show that. So despite that, it's not specific. It's just be as a pitfall for liposarcoma. Sarcomatoid carcinomas is definitely a differential, but again, typically, and I'll show you examples of that as well, you get more of a more typical spindle cell morphology. So I do not consider lipoid subtype is a subtype. It is not sarcomatoid, which is a totally different beast with a much higher rate of disease progression. So that's something that's very important. And then other things to think about is like a signet ring adenocarcinoma, either primary or metastatic. And really for that, it would be site-specific mucin stains would be positive, and you really would have any of these lipoblast-like cells. So that's lipoid subtype. Next, I'm going to talk about lymphoepithelioma-like urothelial carcinoma. And this is a sort of prototypical kind of low power patient appearance of this. If you've signed out head neck as well as I used to, you may have heard of this term. And this is sort of sharing my age here now. The sort of Rago and the Schminke patterns of lymphoepithelial-like carcinoma, where you get this sort of nested-like pattern. I shouldn't say nested, but the sort of cohesive epithelioid nests, or you get this sort of dispersed pattern. They're both flavors of lymphoepithelial-like carcinoma of the sinonasal cavity that are EBV positive. These are EBV negative, but you get the same morphologic spectrum. So here's one of this lymphoepithelial-like carcinoma, these invasive kind of cohesive epithelioid nests of tumor cells intermixed with typically lymphocytic. Sometimes you get neutrophilic, but typically this background inflammation, but it's more cohesive nests. Here, I think people would probably recognize that, okay, this is just a super inflamed urothelial cancer, essentially, so to speak. That's basically what this is, but you get this sort of cohesive nests in here, and sometimes you get some intraepithelial inflammatory infiltrate. The other pattern that you can get is this, and I'll show you higher power here, but I want to draw your attention again that in this case, there is actually a mixed lymphoepithelioma-like carcinoma here, and I'll show you higher power as I promise, but overlying it is our friend, the lipoid or lipid-rich urothelial carcinoma. So just as a reminder that these patterns frequently coexist. But higher power here, this is the one that I think probably you get more in trouble and potentially overcalling as lymphoma or missing it as just inflammation or something like that, because you get the tumor cells are in here, but they're very subtle. It's unlike the other one. They're both flavors of lymphoepithelioma, just like you do in the head neck. So just kind of appreciate you get two different patterns. But this is the one where the inflammatory cells are essentially masking the tumor cells. A real pitfall is actually when these things go to nodes, and they can really kind of, you obviously have this dense lymphoid infiltrate that is a normal node pattern, but very subtly you do actually have some epithelioid components of tumor cells. So in cases like this, you definitely want to use stains, and they stain like your typical urothelial cancer with either some GATA, P63, and keratin. They're all keratin positive, so just something to at least kind of think about. So if if you're these are EBV negative, your top differential is obviously a lymphoma, potentially inflammation, or just benign or small cell carcinoma as well. Molecularly, they do actually interestingly show a basal-like phenotype. If you're interested in that, or if you have some knowledge in molecular, they do show that. But importantly, though, if they're mixed, lymphophthaloma-like, like the case I showed you with lipoid or something like other patterns, then all bets are off in terms of outcome. These are probably going to do worse. But if these are pure lymphophthaloma-like, especially with the PD-1 therapy that's been coming along, they actually respond much better. So some data is actually showing that if they're pure lymphophthaloma-like, actually do really well to chemo and potentially better. So I think that's, again, this is one where if you're going to call it, if you're going to appreciate and recognize it, it can be really important because these maybe do better than your regular urothelial cancers and probably better than the other subtypes. So that's lymphopithelioma-like. Glycogen-rich, and I see some questions posting, so I'll stay late after if folks have questions, and I'll try to go through those and answer them. Glycogen-rich, I'll just show you a quick snapshot. It's pretty uncommon, but I wanted to highlight that this frequently, in my opinion, kind of overlaps the sort of lipid or lipoid-rich pattern. So I think that can be a little challenging sometimes, but really the lipid or lipoid-rich, you should have lipoblasts in that. It's not just cytoplasmic clearing versus the glycogen-rich, and how much glycogen do you need? How much clearing do you need to call it? Is sort of, eye of the beholder. But if it's a little focal thing, like, clearing that you sometimes see in urothelial cancer, I don't call it. It's got to be really quite florid. And the way I kind of, remember it is so here's a, deeply invasive glycogen-rich urothelial cancer. You look at this, and I'm going to show you the next image, which is metastatic clear cell renal cell carcinoma to a bladder. That's what you think, other than the chicken wire vasculature, which potentially saves you. But for me, if you look at this, you're like, oh dang, patient has a history of renal cell. You know what? Could this at all be renal cell? That's where I use glycogen-rich. So that's my threshold. It's not just a little clearing. It's got to be so much clearing that it looks like renal cell carcinoma. And again, in cases like this, obviously history is sort of helpful, or obviously doing immunohistochemistry would be really good. And then PCOMA can be another huge pitfall as well, just something to kind of think about as well. But for other things in the differential. So that's glycogen rich. The WHO uses the term clear cell urothelial carcinoma as a synonym. I hate that, and I would absolutely not recommend it because it causes confusion with clear cell adenocarcinoma of the bladder, which is a totally different thing. So I do not use that term anywhere in the report. So personally, or if you want to do it as a parentheses, something, but I prefer the term glycogen rich because clear cell, like in a lot of organ systems, is just bad. I mean, these glycogens probably do worse, but it may cause confusion with other things, and that's not at all what you're thinking about. Giant cell, in the closing minutes, I'll kind of run through some of these. So giant cell urothelial carcinoma, as the name suggests, is you get these, infiltrative tumor nests with these really ugly pleomorphic looking tumor cells that are kind of scattered throughout. This is an aggressive subtype. It used to be called pleomorphic giant cell subtype. It's, very aggressive. Top differential is urothelial cancer with trophoblastic differentiation. Or urothelial carcinoma with osteoclast-rich giant cells, which some have termed, and I'll show you what I mean by that, is a poorly, there is a specific subtype that's called poorly differentiated. But so the top differential is trophoblastic or this osteoclast-rich giant cell. But right now, it's its own subtype, and it's called giant cell subtype. So that's giant cell. Poorly differentiated. So this is where it gets a little bit kind of in a gray zone in terms of terminology. Is where do you do the term poorly differentiated? I get this asked a lot, and really, it doesn't fit into it doesn't look like typical urothelial cancer. It's not a MET or something else like that, and it doesn't. You look at this, and you're like, dang, this doesn't even look like urothelial cancer. That's poorly differentiated. That's where I do. You do immunos, and it's confirming it's not sarcomatoid or anything. It's definitely epithelial. It's just so ugly that it doesn't fit in any other pot. That's pretty much where I use poorly differentiated. You have to make sure it's not sarcomatoid or anything else like that, but that's poorly differentiated. But if you look in the WHO, they sort of highlight that, well, one form of poorly differentiated is osteoclast-rich undifferentiated, and they sort of lump it under the poorly differentiated. We have a paper coming out that's probably recommending that we probably tease this off as a separate subtype because this is distinct. You look at this, and I'll show you images. This looks like this osteoclast rich. You have these multiple nuclei floating in the luminal spaces in here. These are quite aggressive, but they look different. So this is the sort of osteoclast rich urothelial cancer. And you can see this, it looks like tenosynovial giant cell tumor. If you do soft tissue or joint stuff as well, it looks exactly the same. You see the same tumor, giant cell tumor bone. They look very similar. You get these sort of osteoclast rich tumor cells intermixed with these sort of admixed monomorphic component, and they're usually mitotically active. These are tumor cells, but the tumor cells are actually these single cell component, and these osteoclast rich tumor cells are essentially going along for the ride. I mean, they're all neoplastic, so to speak, but the neoplastic cells are actually these single guys in here that are mitotically active. These are osteoclast rich tumor cells. They sort of stain like osteoclasts. I won't go into too much into that, but at least the recommendation that we're making, here's an example, is more traditional urothelial carcinoma with admixed these osteoclast-rich elements in here. And we have a manuscript coming out essentially proposing that, hey, this is a distinct subtype. They look and stain actually very different than your typical poorly differentiated. So, the future's uncertain about this, but the recommendation we're going to make is to kind of, these is not poorly differentiated. I think these probably are its own thing. Poorly differentiated is just ugly. You look at it and it just like doesn't fit in any other pot. Sarcomatoid is one of the, I can do a whole other lecture series, maybe some other time, about spindle cell tumors of the bladder. But essentially, you look at this and it looks like, a spindle cell sarcoma, NOS, fibrosarcoma. You do stains to make sure it's not MPNST, melanoma, METs, all the usual things. So the biggest pitfall with these, especially on a T or IT, you get walls to wall to wall of this. You can do a few stains on a few initial pilot sections of this, but in general, the stains aren't probably not going to work, other than GIST stains, melanoma stains, rhabdo stains. That's all fine, S100, all that kind of stuff. But the most important stain to make this diagnosis is H&E, is going back and actually sampling and finding some traditional urothelial carcinoma elements. Because the minute you find that, you're effectively done. If a patient had another tumor, could it be a collision? I mean, sure, it's possible. And, you want to consider that. But in general, immunos aren't quite helpful with this. It's really H&E. You want to do the exclusionary immunos, but when you have traditional urothelial carcinoma elements, at that point, you're pretty much done. It's sarcomatoid urothelial carcinoma. So here's an example. You look at this and you say, ooh, that sure as heck looks like bone, right? And this looks like, I'd probably argue that this looks like an osteosarcoma. I have no problem with that. However, right next door, there's high-grade papurothelial carcinoma as well. And here's the low power image just to prove. So this is an example of urothelial carcinoma with it's sarcomatoid differentiation, happens to be in the form of osteosarcoma as well. So again, the most helpful feature for sarcomatoid urothelial, whether it's heterologous or whatever, is finding traditional papurothelial carcinoma. And these look like sarcoma NOS. I don't use the term carcinosarcoma, metaplastic carcinoma, spindle cell. Those are really not recommended. It's really sarcomatoid subtype. Top differential is, as I kind of alluded to in some of these things, true sarcomas, METs, or direct invasion, or potentially inflammatory myofibroblastic tumor. So in the last closing minutes, I'll try to fly through at least these divergent differentiation things. Urothelial cancer frequently is pink. So I think one potential pitfall, this is an example of a urothelial carcinoma with squamous differentiation. For me, I tend to hold out for true intercellular bridges or keratin pearl formation to call it squam. You don't want to overcall as everything is a little pink as squam. And the squamous elements actually do make a difference because these typically do not respond to chemo if they're going to give neoadjuvant chemo to these patients. So with urothelial carcinoma with squamous differentiation, it's seemingly straightforward in terms of, oh, there's squamous stuff in it. Well, what constitutes squam? That's where you have to be a little bit careful with this. And I'm not talking about other, primary bladder squams and other things in the differential as well, or direct invasion or METs. But and again, importantly, it's an H&E thing. P63, all the stain, there's no squamous stain. It's H&E. And again, you want to hold out for true keratinization, not just being pink. And then I typically do give a percentage of the squamous, just like I do any of the other subtypes or elements. And there's some data, at least coming, that the percentage of squams may drive how well they do respond to chemo. So I just give the percentages. But direct invasion and METs and other things would be in the differential, as well as a primary bladder squam. And for that, you really want to see no other urothelial carcinoma elements as well in that. urothelial carcinoma with glandular differentiation. Again, you have some typical urothelial carcinoma, and then other areas that have true lumen formation in here with these columnar looking cells. So that's urothelial carcinoma with glandular differentiation. Cytoplasmic mucin is really just not enough. You can use immuno sometimes. Typically, the glandular elements show decreased urothelial marker expression and increased enteric expression. So sometimes that can be helpful to kind of highlight if you're at all uncertain. But it's really more of a diagnostic pitfall because you look at the thing, you're like, this looks really weird. You do want to importantly make sure it's not prostate cancer, because I've had cases where it's have some lawsuit cases pending for that I'm reviewing now that folks have called urothelial carcinoma with glandular differentiation, and you look at it, and there's big prominent nucleoli, and it's actually prostate cancer all along. So you have to make sure you're not dealing with that. So if there's not classic urothelial, apurothelial, or urothelial elements, do stains, especially in men, to make sure it's not prostate. It's a simple thing to miss, and prostate shows up in bladder not infrequently. So that's something to remember. And then the other differential would just be primary bladder adenocarcinoma. And again, with that, you're not going to have traditional urothelial carcinoma elements in the background. These are less common, but also things to be aware of. Urothelial carcinoma with trophoblastic for differentiation. So it's not just these multinucleate tumor cells. It's not the giant cell subtype. They're not osteoclastic. These are actually trophoblastic. They look like trophoblasts in other organ systems and GYN and other things. But if you could do a simple HCG and kind of highlight that. It can be a little bit muddy sometimes because they bleed. The HCG stains, but these patients often present with serum HCG, and sometimes they can follow that. They wouldn't do a serum HCG in a male otherwise. So it can actually be really helpful in making this diagnosis for tracking these patients. And the spectrum of where the threshold, sometimes it can be isolated syncytial trophoblasts all the way to frank choreo. But again, these are usually will stain with HCG, but the serum levels can be helpful. These are usually high-grade tumors, and some of the things you have to just think about if you're seeing giant cells. Kind of highlighted some of these things in my talk now. Think about other things, but trophoblastic is one that I think is probably also underappreciated because they tend to be just considered as pleomorphic, like they're just part of the tumor cells as like a giant cell subtype. So throw an HCG on it, and you'd be surprised. You probably will pick up a few. And I just give the percentages as well. And just remember, GATA is not helpful in picking these up. It really should be HCG or some of the other newer markers for that. The last couple ones are urothelial carcinoma with Mullerian type differentiation. They seemingly look like, so the poster child for this is essentially clear cell adenocarcinoma. They're PAX-A positive, negative for most of the urothelial markers, but sometimes they can show some, but clear cell is the sort of prototype for this. There's some mixed uncertainty as to how these come about. Some people think they arise from Mullerian remnants in the bladder. Others think that these are essentially urachal tumors gone bad, or true urothelial carcinoma that happens to have some PAX8 type differentiation. It's uncertain. And Dr. Lobo and others and Dr. Zhao have a nice study talking about this coming out soon, or at least submitted soon for clear cell adenocarcinoma. So stay tuned for that. And these have a complex molecular profile and definitely do show aggressive behavior. There are a couple urothelial carcinoma subtypes that aren't official variants, but I think are really important to kind of recognize. So here's one, it's an overlying urothelial carcinoma. And then on the invasive component, I mean, you could probably take at least portions of it and take a picture, and this sure looks like angiosarcoma. We have these, vasculocentric things with blister cell looking elements in here. It's not angiosarcoma. This is actually pseudoangiosarcomatous pattern urothelial carcinoma. There's at least one study looking at this. It's not an official subtype, but again, it's something to recognize, and they do poorly. So I actually do document these, even though it's not an official subtype, because they look weird. A, they are aggressive. B, and it looks, as I said, they look like angiosarcoma, but they're not. They stain like typical urothelial cancer, so you're home free there. They don't have any vascular marker expression, but they're high stage, high grade. They do poorly. And then another one is urothelial carcinoma. Sometimes can have these pools of extracellular mucin, but they're not forming lumen formation. So it's not a glandular, differentiation. They look weird. And sometimes the tumor nest can have these kind of chordoid and nested appearances. We did a study in labeling these as, urothelial carcinoma with chordoid features. Another group looked at these and called it essentially the same thing with abundant myxoid stroma. Our group, we have a molecular paper coming out soon about this, so stay tuned. But yeah, so it's just something to kind of be aware of. So I call these urothelial carcinoma with kind of myxoid or chordoid features. And again, I do document it, maybe because I have a bladder interest, but I think these look weird, bottom line. But it gives you a differential. So again, just keep in mind that just because something's not in the WHO doesn't mean it doesn't exist. And here's a really important one. So you look at this and you just say, oh, this high grade, very basaloid looking, no metastasis. It's a primary bladder tumor with a little bit of invasion along the base in here. You could call this a high-grade urothelial carcinoma, no problem. However, because of the basaloid type nature and really no typical, squamous or anything else, looked a little funny. And this one happened to be in a female. We did high-risk HPV and it was positive. And this was not a direct invasion type scenario. So again, just something you want to think about. Occasionally, you can get HPV positive cancers in the bladder. Sometimes these patients often have self-catheterization, so they may potentially be seeding themselves with the infection. But some bladder cancers can have just HPV association. We don't really know what that means necessarily, but they do likely have a unique. My colleague here, Emily Chen, had a nice study looking at the molecular of these, and they seemingly do have a unique molecular profile and may behave more aggressively. So just something to keep in mind on. Don't necessarily need to do HPV issues on all your bladder cancers, but I don't do P16, but just something to keep in mind. If it looks a little bit weird, especially if it's in a female, I have a much higher threshold for tossing on HPV. All right, so with that, I will take any questions. Let me pull the...
Yeah. Thank you, Dr. Sangoi, for this
Sure.
very comprehensive talk dealing with all the intricacies of this rather heterogeneous group of bladder neoplasms. So as I can see, there are a number of questions in the chat box. We'll take them one by one.
Sure.
Our first question is, do you use the number of nuclei as a criteria for the diagnosis of the micropapillary subtype?
Do I use the number of nuclei?
Nuclei.
No, I don't.
I guess in the nest.
Yeah, I don't. I don't. Yeah, I don't. The number of, yeah, I don't. I mean, multiple nests in the lacunar space, but not necessarily the actual counting the nuclei, so I don't.
Okay, Dr. Menon from India, he asks, what are the most common combinations of subtypes that you come across in a same case?
Ooh, that's a good question. I would say so the squamous glandular, micropapillary, and plasmacytoid, I would say, are probably I mean, including differentiation in those as well. So those are the ones. Then maybe kind of nested. Some of the other ones, lipoid, those are probably a little less common. But I would say subtypes, probably plasmacytoid nested, plasmacytoid and micropapillary are probably the two I see more often. And then on the differentiation side, it's squamous, then glandular. So that's why I spent a little bit more time on those, because I think you see those more often. Yeah.
Okay. Our next question is from Dr. Ganesan. She asks how to differentiate true invasion and tangential sections that mimic invasion in a biopsy specimen.
Sure. I won't spend too long. If you check back the prior lecture 2 lectures ago, I think we talked about invasion on those things, but maybe I'd refer to that. But it can be tough. I mean, you cut level sections, and if I see retraction like artifact or things, for at least for potential superficial PT1, that's something that looks like LVI. It's usually not LVI, especially for traditional urothelial cancer. That can be really helpful. That it's probably PT1 invasion.
So another question is, do you normally screen bladder specimens using a 4x or a 10x objective?
Both, both. I do it in pretty much every case. That's just how I do it. I essentially go at low power along one, and then I go high power along the other. Because especially with these, where TURBTs, you can miss small little foci of invasion. So I kind of screen it low, and then I'll run everything through 10, at least 10.
Okay. Is there a minimum criteria to make a diagnosis for these subtypes? I think like a cutoff or.
Sure. Yeah. I mean, one-ish kind of thing. If it's that focal, I really will think twice about it. And especially, I think you kind of have to think about the ones that really matter, right? So like micropapillary and those you don't want to miss. You also don't want to overcall. So if you just think it's a little retraction, superficial thing, a PT1 kind of thing, and you're not quite sure it's micropapillary, you don't want to just, label that, because especially given what's known about that. But if it's true, differentiation subtype, even if it's 5% squamous or whatever, I mention it. I just say, either put it on the top line as invasive. That's how I sign it out, as invasive urothelial carcinoma with subset squamous differentiation, and then in the comment or micro somewhere I give the percentages. You don't have to put it on. You can put it on the top line however you want to do it, but I try to somewhere give the actual percentages. Do your best, and based on the whole case.
I guess the next question is glycogen-rich subtype showed some nested pattern. How can we decide whether this was not a small nested subtype?
That's a good question. Usually the glycogen-rich, if it's large or small, they're usually not small. They usually are large. Your top differential would actually be large nested. Usually large nested don't show cytoplasmic clearing, and the large nested glycogen-rich usually will elicit a desmoplastic response. Large nested doesn't. You look at it, and it's just like in small nested, and you're like, is this normal? Is this for large nested? You're like, is this a normal cut, a funny cut of the papilloepithelial? And the small nested is this just Florid von Brunn's nest proliferation?
We have another question. Dr. Jerasit asks, Dr. Panner recently showed urothelial carcinoma with rhabdosarcomatous component. Is it possible to differentiate that from a plasmacytoid subtype?
Sure. Yeah. I mean, plasmacytoids should not show, myogenin, MyoD1. They both can have plasmacytoid features, but that would be, rhabdomyosarcomas would be sarcoma, right? That would be a sarcomatous differentiation. So that's different than plasmacytoid. So yeah, you can get heterologous. It would be heterologous. I do try to stratify the sarcomatous stuff if it's homologous versus heterologous, mainly when it metastasizes, right? So you get a lung met with, that looks like osteosarcoma, and you're like, oh, what the heck, what's going on? If you know the patient had a prior sarcomatoid urothelial carcinoma with osteo in there, Occam's razor, it's probably coming from that.
Out of all the patterns, what is the most prognostically the worst pattern? Does the proportion of these patterns determine the prognosis?
There's mixed data. It's a great question. There's a mixed data on especially on some of these micropapillary, 5, 10, 20, how do you, and that's where, everybody's using different definitions of micropapillary A, but especially for micropapillary, there's 5, 10-ish may not matter. And some people say 10, 20 and kind of stuff. But at that point, it shouldn't make a difference to you. I mean, it's good to be aware of it, but I just, as pathologists, I mean, you're not going to alter well, if it's 20, I'm not going to call it or something like that. You just report the percentages that you have, but keep in mind that, in general, these, small amounts, may not, necessarily mean anything, but there's literature all over showing that at least there's some data showing that low levels of these do make a difference. I just had a case, actually, I didn't have time to even include it. It was a external review of an outside case. It was 90% traditional papilloepithelial, 10% plasmacytoid that was missed by the outside group. T1 invasion, and I requested the block, did stains, and confirmed that it was a very discrete little patch that looked like plasmacytoid. The follow-up TURBT that was done just this week had a deep NP invasion, and all of the NP invasion was all plasmacytoid, 100%. So it was 10% on the initial and 100% plasmacytoid high grade on the other one. They probably would have done the TURBT either way, but at least they knew when I had mentioned the plasmacytoid that, boy, oh boy, that this may potentially do worse. Our folks do tend to chase plasmacytoid, at least plasmacytoid and micropapillary. They respect those a little bit more.
So our next question is how to approach a patient who has presented with hematuria, cystoscopy with a large tumor on TURBT, which exhibited glandular morphology with focal unremarkable urothelial lining. Colonoscopy, CT pending, but the IHC was positive for keratin 20, SAT-B2, CTX2, as well as beta-catenin showed cytoplasmic membranous positivity, but it was GARA3 negative.
Sure. So basically the question is you get you don't have any typical, I'm guessing, maybe no typical CIS or no typical papilloepithelial. You get a curetting thing and it looks like glandular, right? It could be colon, this, upper GI-ish kind of stuff. What do you do? Where are you kind of stuck with? That's a super common, especially if an academic center, super common problem. I typically don't rely on stains. CK7, 20, things like that. Anything enteric is going to stain enteric. There's some studies showing that nuclear beta-catenin is helpful to suggest GI origin. I mean, you could potentially try it. But I've had primary bladder cancers that also stain with nuclear beta-catenin, so it's not perfect. That might be the only stain that I do. Sometimes if it's a urothelial cancer with glandular differentiation, you may have some P63 and some GATA, but in general, the stains don't help. So if you get a curetting that looks just basically like this infiltrative tumor of this glandular differentiation, whether it's signet ring, mucinous, whatever, I essentially sign these out as, invasive carcinoma with glandular differentiation or adeno with whatever. And I say the differential is primary bladder adeno, urothelial carcinoma with extensive glandular differentiation, because you may not have that, right? You don't know. You might just be sampling all the glandular stuff. So basically primary bladder, whether it's urothelial with glandular diff or primary bladder adeno, urachal. You got to mention urachal because sometimes they may not think about, oh, wait, is this actually coming from the dome? Urachal adeno, and then met or direct invasion. I essentially put it back on them. With glandular stuff, there's really nothing you can do. Stains and all that stuff, there's a waste of time. Because, if it's enteric, it's going to stain enteric.
Again, we have a question on how to distinguish between a poorly differentiated squamous differentiation with no keratin of intracellular bridges versus a urothelial carcinoma.
Poorly differentiated. So I guess I would have trouble confirming it's poorly differentiated squam. If there's no keratin bridge and thing, I might actually just lump that as poorly diff rather than poorly diff squam. You're saying it. So for me to be squam, it needs to show morphologic keratinization or something like that. So if it's poorly diff, it's poorly diff. So a poorly diff, I guess, biologically could be squamous, but I wouldn't, if it's not showing keratinization or prominent intracellular bridges, there's no way for me to even prove it's squamous, right? So how would you know? So at that point, I would just call it a poorly diff. To call it squamous, it needs to look squamous.
So just continuing from that question, we have another question from Dr. Soni from India who asks, is there any IHC to help differentiate between a primary squamous and a urothelial carcinoma with extensive squamous differentiation?
No, because anything squamous can be GATA and all those stains. They're, P63. I haven't found any of the stains kind of helpful. The only thing I probably would do in anything squamous-y or a little fishy looking is actually HPV. That's one where you would probably want to do and just make sure, because sometimes they don't realize you get a deeply invasive, especially on a high grade thing. They don't even consider it in the females that it's actually coming from either cervix or vagina, vulva, something like that. And in that case, if it's HPV positive, still could be primary bladder, but at least get them to think, oh, maybe it's actually the outside in and not inside out. So HPV would actually be that's the one stain I would do.
What is your experience on having a glandular and squamous differentiation in the same tumor? Do you come across it frequently?
Yeah. I would say yeah. And then frequently you get, like I said, a little bit of squamous. It's like an a la carte buffet. You get a little squam and a little plasmacytoid. You get a little bit of everything. So yeah, it's sometimes you just get one, but it seems like as soon as you get like 2, 3, 4, it's just they all kind of pool in.
So Dr. Shilpi Jha asks, can plasmacytoid variant show a retained ECAD expression?
Yes, absolutely. Yeah. So it's probably 15 some odd percent. So in that case, if it's classic, just call it. But if it's not, then I usually will say, it could very well still be, but if it's not perfect, I won't call it. I don't have to use stains. If it's morphologically classic, I wouldn't do it. But it's more of that pleomorphic desmoplastic one, I would probably want to do stains. But yeah, ECAD's not perfect. It has not been, I will tell you, ECAD has not been looked at in all the different subtypes. And things like that. So, you have to be a little bit careful. We have a paper actually coming out that the osteoclast-rich thing that I showed with the sort of plasmacytoid, the monomorphic component can actually have ECAD loss and very much stain like plasmacytoid. So you have to be a little bit careful.
So Dr. Sandhya has asked, all these variants, they all have a bad prognosis. So is the conventional component always high grade?
Ooh, that's a great question. Yeah, I would say almost undoubtedly. Almost undoubtedly. In general, if I'm doing invasion, I pretty much am starting out at high grade. I have done low grade invasion. I've never seen a low grade invasion with some subtype in general. So that's the other thing is the subtype. There's two spins. Either you morphologically recognize him, but Dr. Panera has a couple good lectures as well. And I think actually at the India conference last year, he gave that, and the way he spinned it was like, rather than thinking of subtypes and all these things, think about it as like, deceptively low and things like that. Because I think, if you look at nested, it looks low grade, cytologically sometimes low grade. It's not. It's a high grade tumor. So all the subtypes and differentiations by definition are high grade.
Based on your experience, how raised is the beta HCG in a case of urothelial carcinoma with trophoblastic differentiation?
Not pregnancy level, but not normal level. So it can be quite variable. But I think that's one where if you recognize that these are not pleomorphic giants, these are just not it's not just tumor giant cells. They're actually, I mean, they're tumor, but it's not just pleomorphic. Throw the HCG on there, especially on a men, then get them to do the serum beta HCG. It can be super helpful too. Because why would you do HCG, serum HCG on a bladder tumor in a man?
Yeah, she also says that she had a case of a female patient with slightly raised beta HCG levels, but with a
Yeah,
bladder mass. So they initially
yeah,
thought to the patient to have a missed abortion.
absolutely, absolutely, yeah.
So the last question is probably related to your last lecture. So Dr. Adil Ashraf asks if there's a high-grade bladder urothelial carcinoma, that's a T1, lamina propria invasion with no muscularis invasion, and the biopsy from the prostatic urethra showed similar tumor deposits involving the prostatic glands, but not involving the stroma. How do we confirm it if it is spread from the urothelial or is it a coexisting prostatic cancer? And what will be the stage for this?
Oof. Let's see. Reread the question. So you have a T1 invasive bladder cancer. Yeah, so in that case, this is like in the biopsies from the prostatic urethra, I essentially put that on them. Assuming it's not prostate cancer. I assume you're saying it's all bladder cancer. Essentially, going back to the prior lectures, the staging is kind of it's prostatic urethra. If it's direct invasion from the bladder, PT4 versus PT2, I kind of just say involving fibromuscular tissues, and then ask them to they know usually when they're looking in there, there's if it's a urethral origin or a bladder origin.
Dr. Rupanita Biswal asks when to call true lumina formation for cases to call them as glandular.
That's a great question. It's how much bending do you need? And it's sort of subjective, just a little, microcysting, as I showed, I tend not to do it. It really needs to look enteric to me with apical looking nuclei. This is for invasive looking stuff. Mucin itself doesn't count. It really needs to have actual apical lumen formation for me to call it glandular.
Given the aggressive nature of plasmacytoid urothelial carcinomas, what is your perspective on the potential role and clinical relevance of HER2 expression in these tumors?
I mean, there's some people using HER2. It's institution dependent on every bladder cancer, right? They're just throwing HER2. And I think it's especially now with the breast criteria, dropping to 1+ and this. So at least our folks, oddly, are probably still doing more micropapillary only right now. But I mean, the data is quite variable on that.
And our last question is, WHO says, I think the glandular differentiation, which you was talking about earlier, should mimic more like colonic. So does that mean that it should be the columnar pseudostratified with the dirty necrosis?
Either one, just more, luminal. The necrosis thing, I mean, I said, you obviously want to think about colon cancer method, but a primary bladder adeno or a bladder adeno with glandular, they can also show some necrosis kind of stuff. But in general, yeah, the Mets and all the things, textbooks say it's dirty necrosis and all that, but yeah, the true lumen formation is what I tend to essentially hold out for. But again, I don't use stains other than potentially nuclear beta-catenin. That might be the only one that I potentially do, but I actually don't do stains. I might put the rest of the bladder tumor in to make sure if I see some traditional urothelial carcinoma, because then at that point you're done. It's urothelial carcinoma with glandular differentiation, but get them to at least consider, direct invasion met or urachal for sure.
So that's the end of our questions.
Okay.
So thank you so much, Dr. Sangoi, for this great lecture.
Sure.
And yeah, for all our participants who have joined, I shall just share my screen. Our next lecture, yeah. 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 So our next lecture is on the 6th of June. Dr. Jasraman Dillon will be joining us again. And Dr. Dillon will be talking this time on cribriform lesions of the prostate gland. So yeah, we'll be circulating this flyer. So yeah, please join and register. Yeah.
Or you can just scan this QR code and join right now. Register right now.
Yeah.
We can keep it for 1 or 2 minutes.
Okay.
So thank you, Dr. Ankur,
Sure.
for
Thank
the
you so much
next
for the invitation.
excellent session.
Yes,
So-
we are very grateful, Dr. Ankur Sangoi, for actually keeping Dr. Mohanty's legacy and memory alive through these genitourinary pathology lectures. Yeah. And we're looking forward to a good series, yeah.
Indeed. This will be good.
Should I stop sharing, Dr. Bedi?
Yes, some people are asking that I should provide the Zoom link also for registration. So just a moment.
It's a lot of work, Drs. Bedi and Lobo, to organize all these talks and coordinating this. You guys have, this is your first day. This is flawless, just by the way. You guys have, it's not easy to organize all these things. So you guys have done a fantastic job, and we have a great lineup of speakers. I'm super excited to watch all the other sessions. So it's going to be good.
Yes. So we are now, I'm sharing the link in the chat also. So those who can't scan, they can just click on this link and register for the next session. So it's my pleasure. It's basically all teamwork and lot of support from Anandi also, from Dr. Santosh and all of you. Thank you.
Thank you, Dr. Sangoi. Thank you very much. And yeah, thank you, Dr. Bedi. Yeah, we can.
Yes. We can end it now.
Yep.
Yes. Thank you.
All right. Bye-bye.
Bye-bye. Thank you so much.